Good afternoon, everyone. My name is Dr. Jerry Krishnan. I'm the Associate Vice Chancellor for Population Health. And on behalf of the University of Illinois, I am really pleased today to have a chance to have you all meet Dr. Eliseo Perez-Stable. And with that, we're going to have our Vice Chancellor for Health Affairs, Dr. Bob Barish, kick us off by giving an introduction to the series. Dr. Barish.
Thank you, Jerry, and good afternoon, and welcome to another of our UI Health Distinguished Scholar Series. The Office of the Vice Chancellor for Health Affairs is pleased to present this collaboration among population health sciences. Many of our chiefs, who you will hear from today, are Chief Medical Officer, Chief Clinical Officer, Chief Nursing Officer, Chief Quality Officer, and our Chief Diversity and Community Health Equity Officer. This series is intended to offer an opportunity to learn from and share with nationally recognized healthcare leaders. I would like to offer a very special welcome to our distinguished guest, Director of the National Institute on Minority Health and Health Disparities, Eliseo Perez-Stable. Thank you for taking the time out of your extraordinarily busy schedule to share your experience and expertise with us today. We've been looking forward for this, quite frankly, for a long time. This seminar series is very exciting to see come to fruition. Several years ago, I approached Dr. Krishnan and others with the idea to engage healthcare thought leaders from across the nation in meaningful conversations so that we may share their expertise with our local community to better serve our patients. We wanted to get rid of traditional slide presentations and host more intimate conversations with notable experts that can inform our operations and healthcare delivery. This is an exceptional opportunity to engage with a national leader from the NIH, especially in the area of minority health and disparities. In our pursuit of health equity, we are certain to learn and gain deeper insights into this work through the experiences of Dr. Perez-Stable and others at the NIH. So it's with great pleasure that we welcome our UI Health Distinguished Scholar, Dr. Perez-Stable, for this virtual fireside chat. And before we begin our conversation, it's also my pleasure to welcome UIC's Interim Chancellor, Javier Reyes. As Dr. Reyes takes on this responsibility, we are happy to have him with us today to engage in this national conversation and underscore the university's commitment to minority health and health equity. Dr. Reyes.
Thank you, Dr. Barris, and welcome, Dr. Perez-Stable. It's a truly honor to have you here with us today. I mean, as you know, UIC is a university in which we are committed to diversity, social justice, equity, and inclusion. Our classifications as an HSI, MSI, and a PC institutions show that we operationalize on this commitment in everything we do. We are Chicago's largest public research university, but we are committed to the community health and healthcare through our federally qualified health centers. A clear example of this I just wanted to mention is our Hispanic Center of Excellence in the College of Medicine that aims to improve the health and wellness of our Latinx communities in Illinois. And through it, our team delivers programs that increase the number of outstanding Latino and Hispanic applicants pursuing healthcare careers. Our ability to harness the innovation and training excellence from the diverse members of our faculty in health sciences colleges, hospitals, and clinics, it really helps us benefit our communities and not only in Chicago, but across the state of Illinois and beyond. As you know, we have taken this idea of the Hispanic Center of Excellence and taken this idea that we are a Research One Hispanic Serving University, and we have now established a similar type of program with all the 20 other HSIs that are R1 across the nation, forming the Hispanic Serving Research Universities Alliance, where we intend to really leverage and what we've learned from the Hispanic Center of Excellence and focus it not only in the medical fields, but also in other fields to double the number of Hispanic doctoral students enrolled at our universities, increase by 20% the Hispanic professorate in our universities, and be a pipeline of talent to other universities seeking to diversify their faculty, just like the College of Medicine and Health Sciences have been the pipeline, not only for the state of Illinois, but for the nation when it comes to Latino talent and physicians and people in the medical fields. So it is great to have you here, and I look forward to your presentation and hear from you, and to this be another step in building a relationship where you can see and we can find ways to leverage the tremendous potential that exists here at UIC, because we're part of a great city because we're already a diverse institution and we're committed to that mission for our social justice, equity, inclusion, and diversity. So thank you very much, and I look forward to your presentation.
Great. Thank you so much, Chancellor Reyes. This now gives me the great opportunity to introduce you all to Dr. Eliseo Perez-Stable, and then we'll have each of our other panelists also have a chance to introduce themselves before we go into our discussion. So let me just say that Dr. Perez-Stable is the director, as you've heard, of the National Institute on Minority Health and Health Disparities, also known as NIMHD at the National Institutes of Health. He oversees its annual budget to advance the science of minority health and health disparities research. His institute is the lead organization at NIH for planning, reviewing, coordinating, and evaluating minority health and health disparities research activities. It also promotes diversity in the biomedical workforce, supports research capacity at less resource institutions, training underrepresented students and serving populations with health disparities, supports inclusive participation in all clinical research, promotes information dissemination through regular electronic communications, public health outreach, and scientific presentations. And really today's session in part is part of that portfolio of getting the word out and hearing from us all the great work that's happening in Chicago, not only at UIC, but across all the organizations that are participating in today's session. Prior to becoming the NIMHD director, Dr. Perez-Stable was a professor of medicine and chief of the Division of General Internal Medicine at UCSF in San Francisco. Dr. Perez-Stable's research interests have centered on improving the health of racial and ethnic minorities through effective prevention measures, understanding underlying causes of health disparities, and advancing patient-centered care for underserved populations. So you can see his background is aligned extremely well with UI Health's mission and focus to eliminate health disparities. He's a scholar, has published more than 300 peer-reviewed papers, and has been continuously funded, or I should say was continuously funded until he became the director for 30 years through NIH before becoming director. Dr. Perez-Stable was elected to the National Academy of Medicine, formerly called the Institute of Medicine of the National Academy of Science, in 2001, and the American Society of Clinical Investigation in 1996. So he's clearly nationally and internationally recognized for his work. His background includes a Bachelor of Arts in Chemistry in 1974, a medical degree in 1978 from the University of Miami. He then completed his primary care internal medicine residency and research fellowship in general internal medicine at UCSF. So you can see a tremendous training and clinical and research and administrative background, and it can't be more pleased to welcome him to the Distinguished Scholar Series here. So with that as an introduction, we'll have a brief introduction by the rest of our panelists. We'll be beginning with Dr. Bleasdale.
Right, thank you and welcome. I'm Dr. Susan Bleasdale. I'm the Chief Quality Officer for UI Health. I'm an infectious disease physician. Very excited to hear from you, as our mission at UI Health is to advance health for everyone through outstanding clinical care research and social responsibility. And I want to learn more from you as we are working on health equity outcomes through several pilots in our program here at UI Health. Thanks for coming.
Thank you so much, Dr. Bleasdale. Dr. Hughes-Dillard.
Hi, I am Dr. Ty Hughes-Dillard. I am the Chief Nursing Officer here at UI Health, and I'm excited to learn more. So let's sit back and let's enjoy.
Thank you so much. And to our Dean, Dr. Mark Rosenblatt.
Mark Rosenblatt, I'm Executive Dean of the College of Medicine, and it's really just a pleasure to have Dr. Perez-Stable here today. Of course, the social responsibility is a key tenet of our mission in terms of the patients that we care for, the students we educate, and of course, the research that is ongoing within the College of Medicine and beyond. So thank you.
Thank you. And of course, our Vice Chancellor for Research, Dr. Groden.
Thank you, Dr. Krishnan. I'm Joanna Groden. I'm the Vice Chancellor for Research. I have the honor of representing our research portfolio as it nears $500 million, almost half of which comes from NIH, to which we are eternally grateful, especially many of the institutes heart, lung, and blood, NCI, NEI, and NIA that really are linked with a commitment to health equity research and stitched together with access and excellence as our centerpiece. So again, welcome to the panel and to our visitor today. Thank you.
Wonderful. Thank you so much. So we'll then move over into our discussion stage, and I would like to invite our attendees to participate actively in this forum. We have over about 90 or so individuals currently on the panel or as participants. We expect even more to join over time. As all of you registered, you are asked to identify specific questions you had for our distinguished scholar. And we've had a chance to take some of those questions, and we'll begin with really asking our distinguished scholar some of these questions. As the discussion goes on, if you have additional questions you'd like to ask, I'd like to really encourage all of you to use the Q&A button as part of the seminar series to submit these questions. Our panelists will have a chance to review those and to have as many of these answered as possible. Please note that this session is being recorded and will be made available on the Distinguished Scholar website at UI Health. So with that as a little background, let's have a chance to speak to our guest. Dr. Perez-Stable, you know that this session is in part to really get to know you as a person.
Mm-hmm.
We are extremely pleased and impressed at all that you've done in a short time in your tenure. And I guess we'd like to hear a little bit more about how did you become the director?
So thank you, first of all, for this invitation. I just want to briefly say I'm so appreciative of this honor. One of the roles of coming to NIMHD or to NIH was that all of a sudden I had to sort of really put a real control on how many places can I go and how often am I going to be on a plane. Of course, now it's virtual, and then it got more intense because it became virtual. So everybody, you could do one a week. So I love this format. I think it's very great. It must have been really hard, not just to get me on for 3 hours, but get all these leaders together and block out the time. That being at UCSF, I remember that. I'll say a couple of things about me first. I'm an immigrant. I came from Cuba. That's where I was born when I was 8 years old. My father was a physician. So that was sort of my sort of background in socioeconomic and times. It was 1960 when I immigrated. I did end up married with a woman who's also an immigrant from Latin America, although both our sons were born in San Francisco. So I'll leave it at that. I consider myself fully bicultural. I guess in the linguistic world, people refer to me as sort of a heritage speaker, but I'm pretty good at Spanish and reading and writing. And I'm proud to say both of my sons are as well. At UC, I'm a generalist as well. I think that's just sort of an identity, a professional identity that that resonates with me, although I gave up being a real doctor back in 2015 when I moved to NIH. I couldn't be a primary care doctor running an institute. But for all the longest time, 37 years, I had a practice of patients that I followed, people who really considered me their doctor. And that's one of the most important aspects of my life, definitely professionally. It kept me connected to real people, I think, and really gave me a sense of, sort of the individual or the small contributions, what makes to people, individuals' lives, as opposed to thinking always of systems and populations. And I miss it, but people, you make choices for good reasons. But it does inform my perspectives on science and informs my perspectives on what's important. So I'll put that out as well as background. So at UCSF, I probably had reached my ceiling. I was never one to go shopping around, see if there was a good job somewhere else. I tried doing that once to see if I could improve my lot, and it failed miserably. I visited one place that I thought was pretty good, but then I wasn't selected. And I visited another place that visiting it made me realize I would never want to be there. to lead it. Both were in great cities, nothing wrong with the institutions, but it was just the units. And at UCSF, I was a division chief, ran a big unit. We had 60 faculty. We saw a lot of patients. We did a lot of research. I dealt with the department chair all the time, but also above that intermittently. So the Institute was one that I had never gotten any grants from. My grant funding was NCI, NIDA, NIA, and AHRQ. So it wasn't a place I had gone for funding, although I'd followed its foundation. I did apply once and we didn't get funded. But at one point I was in 2010, I think it was, I was asked to be on the NIA council by Richard Hodis. So I said yes, of course, because they had been funding me for some time. And that really opened my eyes as to what NIH was like. So prior to that, it was, program officers I dealt with. Some were nice, some were really helpful, some were not. But generally, I was not one to go in and go visit people just to get to know them. And I did, was on campus a few times, but being on council really gave me another perspective. I quickly was asked to work on a project with them related to their minority task force. I got to know Marie Bernard well because she was the deputy director at the time, and Richard subsequently I've worked very closely with him. And so when John Ruffin retired in March of 2014, I certainly took note and reflected on the idea of applying. Now, I did not get requests from NIH search committee saying you should apply, but I did get requests from people I knew in the community and in the policy world, in the Latino Hispanic world especially. And so I did apply. I was invited for the panel interview. The panel interview was actually, and now I know how NIH does it. They write the questions, everyone gets the same questions. The panel was co-chaired by Dr. Fauci and Gary Gibbons, people I've gotten to know very well since. And it went, I thought it went well, it lasted 45 minutes, 50 minutes, whatever. And I came home, and a couple of, maybe 2 weeks, 3 weeks later, Bob Croyle, who I don't know if any of you know him, he's now retired as director of the Division of Cancer Prevention Sciences, I think is the title of it, at NCI, called me. I had known him for years and said, I'm on the search committee. I couldn't go to the interview, but I'd like to talk to you about the process and, the job. And when he sort of offline, right? And he said, it's not just you're in charge of an institute. You would get the table with the NIH director, and you would be, the first person that does this kind of research or has done this kind of research to be there. John Ruffin, by the way, is a basic scientist who had been in government since the early 90s. And they're really, this whole sort of phenotype of science, public health science, clinical science, behavioral science, whatever you want to flavor you want to call it, on the human side of things, just wasn't prominent at all in leadership at NIH, zero, not among an institute director. And here was an opportunity potentially to do that. And it gave me the sense of what the potential was for this position. And so went for the second visit, which was very much treated like a VIP. That's how they deal with second visits. I met with Francis, we had dinner. I think I got maybe one or two hard questions, one of them from him. But it was generally a very positive experience. I think it was on the January 15th of 2015, so it was a Friday, and then it was radio silence for 2 months, and sort of the anxiety of, am I going, am I staying, what's going to happen? Of course, everything had to be completely confidential. I did tell my chair, and his only response was congratulations. And I go, what? I haven't been offered anything yet. So, I'm just telling you that you're going to get a call. and maybe he already had been called. I don't know. But anyway, that's how the process went. And then when I was offered the position, we as me and my family were really ready to say yes. Claudia, my wife, was very supportive. My older son was just finishing college, and my younger son was just finishing high school. So personally, it was a good time to think about this kind of a big move. And career-wise, at the time, I felt, well, it's not the end of the world if I stop seeing patients, which is something I had said I would never do. But
wow, what a story! I think I'd like to hear more from the panelists as well about how they made, career decisions. But the takeaway I have is that you'd spent decades establishing an identity, and this opportunity came up, and you put your hand up and said, well, let me give this a try. And that takes courage to change. So maybe I'd like to ask some of our panelists here about that courage. Dean Rosenblatt, can I put you on the spot? And how did you raise your hand to become dean? How did that happen? Tell us more about that decision.
Well, I think as Dr. Perez-Stable mentioned, it's really a matter of timing, right? To understand, is this the right time to change jobs and to take on a new challenge? I was already at the institution. I was at UIC as head of the Department of Ophthalmology and Visual Sciences, and really got to know the institution and love the institution over a course of 4 or 5 years. But one also sees new directions and new opportunities to build within the existing culture. And when I had a chance to apply for the dean's job, I did. Again, also running the gauntlet and a lot of stops and starts, and then a lot of time before when you start the journey to when it ends. But again, the more I progressed through the process and got to know more about leadership and other heads, it just became clear it was a wonderful opportunity to really try to make a difference beyond what I could do as a department head. And again, I still maintain my laboratory and still spend some time in the clinic trying to keep those attachments, but I do feel the struggle that Eliseo mentioned as well.
Great, thank you. And again, this is such an important topic of when do you go from working at what you're really good at to maybe taking that big giant next step of leadership. And maybe does anyone else on the panel want to weigh in on this? I think we've all struggled with this, and I'm just going to open it up. Anyone else want to weigh in on this? Oh, great. Dr. Hughes Dillard. Yeah, tell us.
Hi, thank you. So I agree. It takes great courage. My specialty has always been in emergency medicine. I was an emergency trauma nurse at University of Chicago for many years. And so when they wanted leaders or leaders who wanted to make change, I was hesitant. I had great parenting, I'll say, and my dad was the one who said, you can't be a leader behind the scene. You have to be a leader in the front. And so when you have those opportunities to lead, you have to step out on courage and faith. And then you have to do what's best, what's innately inside of you to do the best thing for the people you've decided to serve. And so when asked to be the first African-American CNO here at UI Health, yes, I was terrified. But I knew I had a lot to give, and I knew that I could relate to this community. I'm a Southside girl, so I could relate to this community, and I could provide some good direction and to make sure that the healthcare that they're receiving is stellar. So yes, you have to jump out on faith and be courageous.
Jerry, if I may, just for a minute, Eliseo, I was called into the office of Dr. Don Wilson. I know you know Don Wilson at the University of Maryland when he was dean, and I was chief of emergency medical services. I assumed I was being fired because nobody gets called into Dr. Wilson's office. And I showed up at 8 a.m, and he said, Bob, I want you to be my dean for clinical affairs. Any questions? The meeting lasted about 2 minutes, shook his hand, and that's what happened. So sometimes, Jerry, these things just present themselves, and you have to just take the opportunity as it occurs.
Yeah, there's courage though, right? I mean, I think you had to believe in yourself, and also, you don't have all the facts about what that means when you're stepping into that frontier. But what do you think? Is that true, Bob? I mean, did you know what it actually meant?
Well, if they had the courage to offer me the position, I thought I should have the courage to take it. You know, it works both ways. So
Absolutely.
One of the factors, Jerry, that influenced me was being inspired by Francis Collins as a leader. And, you know, I had not really interacted with him personally until I interviewed for the job. And that just grew over time. And for me personally, that, you know, if I look back on my career, you know, when I made these different steps, and when I first became a faculty member, then eventually became division chief, there was always some person like you said, Bob, who said basically, well, you're going to do this, or you'll be acting, and let's see what happens. And so I think that was a big influence for me too.
Right. Jerry, just one other comment. I think that if people see something in you that they see that you could be a leader, and that's your next role, you have to accept that. So I think that's what happens. And Eliseo, I think in some ways that happened to you as well. And so you never know the twists and turns of life, but you have to be ready to accept increasing responsibility.
Great, thank you. Dr. Bleasdale, I think you wanted to say something?
Yeah, because I think, like you mentioned, Dr. Barish, a little bit of the twist and turns. I had a similar pathway that was not very linear. I was originally in private practice for about 5 years doing just clinical work, and then actually took a break to be home with my young children, and then joined the faculty here at UIC and UI Health. And throughout that, I had connections with my mentorship through infection prevention. A lot of my research and my training was around population health, and so connecting to that. And then now doing work in more general population health and quality for the hospital was a reasonable and making a lot of sense in that transition. But I had a question for you, because I think it was a challenge for me. I really enjoyed my clinical work. I still enjoy the little bit of clinical work that I do, but this was a big decision for you to change away from your clinical work when you did identify in that way. And so I think I'm curious about what your day-to-day looks like, and then what you find that inspires you now in your daily work, because it seems like in your opening comments that maybe, you know, your patient care identity was your inspiration originally.
Well, I point that out because I didn't want to leave clinical care behind, because as a physician, I think that was an important part of my identity. You know, that, and I was proud of the work and did derive a lot of, you know, energy from that. But you know, day-to-day work as an institute director is quite different. Lots of meetings. Everyone that reports to me directly, you know, I need to have one-on-ones with them on a certain frequency, especially my deputy director, my executive officer, who's the chief administrator, and then my scientific director on the intramural side, intramural program. Many are aware, hopefully everyone's aware, that NIH has an internal research program called intramural research. And one of the benefits, by the way, of being an institute director is that I was offered the option of having my own lab, my own research. So I could continue working in scientific topics, which I very much took on. It's based at heart, lung, and blood, so that you avoid conflicts. Everything's virtual now, so a lot of times meetings, or not everything, but almost everything has been virtual, back to back to back. You know, it's been 2 years. We're now saying that it's going to be, that's the way it's going to be. But we do some really, and there's tons of email. In an interview that he was published in the Washington Post on Sunday, Dr. Fauci said he gets 4,000 emails a day. I definitely don't approximate that, but you know, you do take a certain responsibility in responding to most messages people send to you, although you'd be surprised what sometimes people write and ask for directly to me. And then some people say, oh, I can get a hold of them. So I'm always surprised by that. We have monthly scientific roundtable meetings in the Institute. I started that when I arrived. It was with the idea of promoting thinking about, well, what new concepts, and the staff were really ready for it, because there was just an outpouring of, you know, we should do immigrant health, we should do social epigenomics, we should do health IT, we should do this. We talked about structural racism back then. We actually sponsored a scientific workshop on it, and sponsored a special issue of ethnicity and disease on the topic, which very timely came out in the spring of 2020. And we've got to write a commentary that really put out our perspective on this, and ours was at that point with Monica Webb Hooper, the new deputy director. I also do a lot of managing up. So the directors meet on a weekly basis, just about. We used to say we sat around the table. Now we sit around the Zoom room for the most part. We've had some hybrid meetings, although for the summer we abandoned those. And it's been a great opportunity to get a working relationship with folks. So lots of administrative tasks, but also discussions about science. And probably the most fun thing that I do, I told somebody years ago, and still is making funding decisions. We're a small institute, so I get to hear most of the highly rated grants, sort of very brief summaries. Inevitably there's going to be every council round one grant where, got a real good score, but not really a good fit for us. And we do try to find a home for the grant, almost always do. But it's exciting to hear about the science. I learn a lot from listening, and not, I also from reading, but, I think I do prefer that model for learning about especially larger volumes of information. And the staff, I think, then also get to present what their assessment of a grant is, and we keep working on it. They're not faculty, so it's not the exact same parallel, but they're mostly all PhDs, some MDs in our institute, but not many. I think I have to say that the biggest inspiration was our response to the pandemic. And it's now over 2 years ago, but 2020 will never be forgotten for me personally. When we shifted to virtual, this new infection, frankly, I was scared. What was going to happen to the world? I'm sure that these thoughts crossed many people's minds. As a physician, you knew what the potential consequences were. Everything shut down. That was like, wow, we shut down the country in a matter of a couple of weeks. I still remember, I think my deputy director had started, I swore her in one day, and the next day we were all home. And I've seen Monica maybe half a dozen times in 2.5 years, in person, that is. And so I think that the NIH response was amazing. It was under the prior administration with a substantial amount of adversity. Dr. Fauci aside, he has his own hero status recognized universally. All of NIH just mobilized. Dr. Collins sort of called for a special meeting for brainstorming about what are we going to be the science response. And he didn't say vaccine development, drug development. He wanted everything, behavior, public health. At that moment, we still weren't clear on the level of disparities. And then we had to send in one-pagers, or maybe even shorter than that, ideas. And then they selected the ideas for 2-minute presentations. It was literally that kind of intensity, working literally not 24/7, but regularly working on the weekends, and that didn't let up really until the end of 2020. And so that retrospectively inspired me of how we were able to collectively step up from the very every staff member at the institute. Someone said maybe several months ago, I was in a meeting with some group from the White House advisory group, where they made the comment, there was a big uncontrolled fire and the NIH ran to it. And that literally, I think, captures the sentiment of what actually happened in 2020, and in our own small way made that. And then the other issue is addressing the structural racism. When George Floyd was murdered, a lot of people were moved, and Francis was one of them. He was shocked. He sent out a note where he actually put himself out there at risk. Remember, June of 2020. It was early June, so he marched that week when it happened in the rain, and every organization I had ever known about put out statements about the issue of addressing structural racism. So we had a window of opportunity, a door of opportunity, if you wish, to really begin to make a difference on an issue that we all know was not new. And although there has been some regression on that, the door isn't quite as open as it was in 2020. NIH embarked on this Unite process, which has its own life now, and certainly has put us on a path where it's not going to be possible to just say, okay, stop, we're done, we're not going to do this anymore. And so I'm inspired by the courage that it took. Since we talked about courage earlier, because it's not easy, it's going to be painful, and it's not going to be short term. This is not something like, oh, I put a statement, we do a little work, and then we're on to the next topic. No, this is much more rooted into society and institutions, and so we'll see where it takes us. But I'm always optimistic, so we'll move forward.
Great, thank you so much. Yeah, one of the panelists want to follow up on that?
Sure, I will. So you mentioned really how change comes to all our careers. You've mentioned how not only the pandemic, but I think the change in how we look at social justice in the United States and throughout the world has changed you and the Institute. And so I wonder also about the other things that have changed for you. Certainly, we have huge upheaval in the US about not only how we treat one another, an upsurge in gun violence, changes in sort of communication and a bifurcation of our population into two camps primarily. So how do you, I guess yourself, look at how those things affect you, and also the Institute thinking toward how we can make meaningful changes to really address these crises as they keep coming in waves. It's almost overwhelming.
Right. No, thank you for that, Joanna. I should start by saying that NIH tries very much so to stay in the science lane, right? Which is a broad lane, but it is science, and so we don't make policy. We address issues from a scientific perspective, and we inform policy. And I think that a lot of these challenges do present barriers to this. So talking about discrimination and racism is a start, but then the fact that people would deny that that's ever going to be an issue or immediately become defensive is a challenge. And so formulating it as a structural problem does depersonalize it, but it does create more sort of look in the mirror, because the institutions we are part of have been part of this. So it's quite complicated. Being in Washington, and living and breathing political issues, all the time. Of course, we're very cognizant of what the Congress is doing or not doing. I've been in a hearing a couple of times, but of course, they're only focused on certain topics to make them become, the big deal. Although on both sides, they can sometimes come with irrational perspectives as to why we're not doing this or not doing that, or why shouldn't we do this or do this, and not fully understand what NIH's role might be. But NIH is big, has a big budget, and it has had a high level of prestige and support across the board that has changed somewhat in the last couple of years. but it's still pretty high compared to much of the rest of government. So a lot of times, even within government, people look at NIH as the privileged agency as opposed to other parts of the health and human services. But I think that the approach we would take in thinking about this is, fundamentally look, let's generate data. Let's look at what's there. Let's not take a position on the basis of emotion or idea that you have or opinion, but to really orchestrate as much as possible studies that will generate empirical information that will inform, how to proceed. It's clear that we have not made as much progress or hardly any progress in the structural factors that lead to disparities. Much of this relates to individual health or behavior issues, but relates to structural issues, where people live, the opportunities they have, the education they have, and the kinds of work that they are doing. I think that everyone is now more aware that that's really going to be the next area that we need to really delve into. We've actually talked about a poverty moonshot as a way to improve health. There's compelling evidence that the more educated people are, the better health they'll be. So wouldn't that mean that if we do an educational intervention, isn't that good for health? And, I used to think that, no, you need a health outcome to be a grant, but now I'm beginning to think, well, maybe not. Maybe we should be looking at ways to get, third graders to read better. Because they'll be healthier when they get to be 20 years old. I mean, I don't know. I'm just talking a little bit, speculating here, but
Sure.
these are factors that really matter. Yeah.
Yeah, I was going to ask you about, sort of how we communicate in general, not only to third graders about science and research, what certainly I love most of all, but how do we learn to speak and communicate broadly in a way that the general population will trust science and data in order to enable health and better health outcomes? How do we do a better job of that? Because clearly we can do better. And so I'd just love to hear your thoughts about communication style and change there too.
No, I think that's a huge topic that I don't have the magic answer for, but I'll tell you what I think. So as a former clinician, you talk to patients at different levels, but you definitely start with the least common denominator. Concrete, no nuance. If you're sure that something needs to be done, or that's what you think, you don't say, well, is it 90%? No, you say, this is what I'm recommending. And I think that frequently as researchers and clinicians, we get into the, well, we need to do shared decision-making, give them everything, inform all the possible, and there's value to all that. I'm not disagreeing with that, but I think frequently we need to recommend. Now, you're going to recommend a pap smear for a woman. Are you going to say your risk of cervical cancer is 1 in 10,000? No, nobody says that, because then a woman might say, well, why should I bother? It's such a low risk. I'll just take my chances, or it's not that important. And clearly, we need to find that common ground of where I think Dr. Fauci tried to do that. I think he got trapped into a variety of situations where that wasn't happening, but that's what we really focused on. What we weren't ready for was the malicious misinformation that came with this pandemic. There was also misinformation prompted by, politics, or by people who just say, anything coming from Washington, we have to find the other side. But there was also, I think, true malicious intent in some of this, whether it was domestic or otherwise actors in this. And then the facility to do this through social media. We weren't ready. And we contributed to building the mRNA vaccine. We had an effective vaccine. Now, it's not as good as it looked back then, but let's just say at the moment that we had it out in December of 2020, it looked really good. 90% protection, almost completely obliterate mortality of the original wave. And we said, we'll put it out, everybody will come and rush and get it. Well, that didn't happen. there was a third or 40% of the population that said, no way, I'm not going to do it. Don't force me. I'm not going to. And I don't think we were ready for that. I think that means that we have to do a lot more in communication science, in messaging, and anticipate these issues as we move forward. It's not new. This isn't new. It's just that now everything moves so quickly and gets disseminated so quickly that we just really have to get have the experts to get ahead of it. So
yeah, thank you so much, Dr. Perez-Stable. I'm going to just take the prerogative to. We have about 6 minutes left. There's so much here. It's too rich to stop this, but I know that our chief nursing officer, who by the way is a very glass half full kind of person, so she's itching to ask you a question. So I'm going to let her go next, and then we're going to try to see if it's possible to have our interim chancellor ask a second question. We're going to try to get 2 questions in the next 6 minutes. So maybe our questions
I'll be brief.
and our answers can be brief. So
okay, I'll be brief. You're right. I'm not a girl half full or half empty. I'm going to drink the water because I'm going to come up with the solution. So my question is that a surprise for us was that there was a lot of misinformation, as you said, during the COVID pandemic. But tell me, what was a positive or an upside to a surprise during the pandemic?
I mentioned already the incredible willingness of people to mobilize and what can we do. That it didn't, the first week or 2, I was like, okay, vaccines, drugs, what's our role? But clearly, behavior, mental health, substance use, population issues, and then of course this glaring disparities that became evident by the end of March of 2020. So and just this broad scope, and even though I was not seeing patients, I was very much tuned into all the clinical issues that were being presented, talking to people about it, reading about the stories in those initial waves. So I think that in sort of the worst situations that we have experienced as a society, the AIDS epidemic, and it reminded me of the HIV epidemic in the early 1980s in San Francisco, where I took care of so many young men and some women who died, who got very, very sick, and we didn't have a whole lot to do for it. But how the community responded, how the clinicians responded in that context, that's what it reminded me of. Or you also see the underbelly of the profession. You see how people get saying things about, you're putting a chip into my arm, or this was a conspiracy, or it came from another country, and therefore we're going to attack the people who come from that country, as we saw. So I think this incredible response, and then linked to it was this racism issue, this awareness, this awakening about it in 2020 that was unparalleled in the time I've been alive anyway. And I think that those 2 things are things I would hang on. So
Thank you.
Thank you so much, Chancellor Reyes.
Thank you very much. And like you said, Jerry, this has been an incredible conversation. And I think my question relates to, even Dr. Rice has said it many times, that the pandemic showed us big challenges, and it really hurts us in many, many ways. But at the same time, it may have shown us given us some insights into what are the health inequities in the United States, not only that are there, but may have given us a way to identify what's causing them. And perhaps through the different efforts of the pandemic, we would be able to learn from them, and perhaps address them differently than if the pandemic had not happened. So what have we learned about health inequities? That it's not that we know they exist, but because of the pandemic, we may have a different way of addressing them.
Yeah, that's a real challenging question, Javier. I'm not sure because of the awareness change and because of the attention given, it became more than NIMHD or a few other programs that were focused on this, or my disease or this disease. I think now there's an understanding that this is very complex and multi-level. And you can't just push one lever over here. Yes, we can get mammography rates to be the same for everyone and expect that that's going to be a win, and then we're going to move forward. You know, breast cancer mortality is still different for access reasons, for therapy reasons, maybe in some cases, perhaps biological reasons, and certainly in follow-up. So that's just a micro example of how things develop. These are all complex factors. One of the things that I have tried to emphasize as a director has been that the self-identified construct of race and ethnicity is as a social construct, and socioeconomic status or social class are fundamental in influencing health. They're fundamental. There's so much data to support that in every human study, we should measure them and consider them as potential contributors or associate factors, and measure them in a standardized way, just like we would measure hemoglobin A1C or blood pressure. And if you look at the effect of education, for example, or income on mortality, it's hard to find other factors that have such a robust relationship. You know, tobacco smoking, BMI over 35, systolic blood pressure over 160, things like that. Things that most clinicians would say, oh, of course, yeah, that's a problem. You know, but with these other things, people they didn't even know. You know, so how far did your patient go to school? I don't know. You should know, because that's how you talk to them to begin with, but also because it affects their health. And similarly, I think with race ethnicity, to understand where people's lived experience is, that's a factor that, you know, that's at least a door into that. And I think that there's much more awareness of these factors now, and much more awareness that we can't just do one thing. We have to come up with creative ways of doing multiple things together. There is a common fund program being developed. It was discussed at the Council of Councils in January, so it's public. We call it Compass, and it is going to try to do this, to have a community-based driven interventions to address disparities by addressing structural issues. And so we'll see what comes out of that. So look for that in the next hopefully the next 6 months or so.
Great. Well, thank you so much, Dr. Eliseo Perez-Stable. It's I feel like we just scratched the surface, and we're going to have to continue this, I think, in person, and hopefully opportunity to have a broader conversation about all the sub-themes you've identified. I want to take this opportunity to say we're kind of at the end, near the end of the general session. I think you all can see, hopefully, why we launched the UI Health Distinguished Scholar Series about 2 years ago, is in the midst of all of that's going on, there are real people making real differences. And I think we need to understand each other so that we could work, hopefully, together in an era where there's so much use of technology that I think the human component of what makes us who we are and the common threads that we all have, I think, gets lost, you know, with the obfuscation sometimes of technology. So I want to thank Dr. Barish for his, insights to launching the Distinguished Scholar Series to learn from nationally recognized healthcare leaders. How do they think? Why they pursue their vision? How they apply their insights to improve health? I think we just started to really understand from Dr. Perez-Stable what drives him, what makes him tick. So thank you. I want to now ask you, hopefully this worked out. When we launched it, we were hoping to do this in person, Dr. Stable, Perez-Stable, but I think we said, oh, there we go. Beautiful. Okay. All right. So
can you see it now with the background?
Yeah, let's see here. We can see it. We're now, thank you so much. You lifted up the trophy / plaque. We have to use the right word. I think plaque is the right word for the NIH.
Yes.
So we've presented Dr. Perez-Stable a plaque. Please call this a plaque. This is being recorded. Hopefully he'll put this on his office mantle, have it at home as a way of just recognizing everything you're doing. We are very proud as an institution to work in support of your institute's mission, Dr. Perez-Stable, and we want to thank you on behalf of the University of Illinois for what you do. So thank you very much.
Thank you for this. It's beautiful, and yes, I will cherish it for foreseeable future. So thank you very much for this honor.
Thank you. So this concludes our general session. Dr. Perez-Stable, we're giving you a little bit of a break before we come back to you. And for everyone else who has joined us from Chicagoland, actually there's some people from Rockford and Peoria and Springfield as well. So you've attracted an audience from throughout the state. Thank you all to everyone. Stay safe. The pandemic is not over. I think we heard that at the beginning. Take care. Bye-bye.